Okay, begin, clip, roll. Okay, I'm here to talk about ATYR in my short thesis. So this is a pretty confusing company, as you know, a lot of biotechs are confusing. And so we are here to talk about ATYR, ATYR Pharma, developing a drug called efficacy for sarcoidosis. So I am certain that this drug does not work. A lot of people always ask me, well, how can you be so sure? Well, there are ways to being sure, and I'll try to convince you right now. Let me see if, in mathematics, the definition of a proof is a convincing argument that something is true, and convincing means you convince your peers. So here goes. Okay, I drew this a minute ago, forgive the poor art, but basically the company noticed, as did various people in the medical establishment, that AARS, which is acyl amino acid tRNA synthetase. Okay, this is an almost exclusively intracellular protein. You've heard of it, basic biology, the whole tRNA kind of cascade. But evidently, I don't know if it's in some people or in everybody, tRNA, this AARS sneaks out of the body into the bloodstream, and for some patients, very rare, not many reported cases, maybe a couple hundred reported cases, okay? They form antibodies, called these Jo-1 antibodies, to ARS. And the phenotype or sequelae is this kind of weird myositis ILD syndrome, okay? And so the Jo-1 patient has these antibodies swimming around and has this rough syndrome, fine. That is sort of reality. There's no debating this. This is all true. So now we go to the ILD patient. The ILD patient does not have Jo-1 antibodies, right? Something else is causing their sarcoidosis. And we don't know what that is exactly, but they have sarcoid, lung sarcoid, and they don't have any AARS antibodies. So the therapeutic theory here is, despite the fact that their AARS pathway is not blocked, it's not problematic in any way, that we're going to give a synthetic AARS, that I guess I should color this one in maybe purple, and the green one is native. We're just going to give a synthetic AARS with a FC region, and we're in essence supplementing the patient's kind of natural ARS or whatever is happening when this protein leaks into the bloodstream. And the theory is that, well, if you don't have antibodies to ARS, you don't get this myositis or ILD. But I'm not sure I follow this hypothesis, where the more ARS I have, the less myositis or ILD I have, because I think we've proven that the patient's ILD is not caused by antibodies to ARS. It's caused by something else. So adding more enzyme, maybe the signal it's creating could lower the myositis or ILD, but it's sort of hard to imagine that the person's, whatever's causing the scleroderma, is being interfered with here. Boosting the ARS signal, if that signal even exists, is something that, you would think maybe could stop ILD or myositis, because when you have an antibody to that, you get myositis and ILD. So it's kind of this weird hypothesis where it's like, even though my pathway isn't impaired, I'm going to try to jack up the signal. Now, it's not the craziest hypothesis in the world, but there's a problem with it. The company already tried this. They tried it with their old drug, ATYR 1940, and they gave it to these patients, the myositis patients. And I'll just make that drug in orange, but it was basically the same thing. It was a larger domain. It was almost the full protein instead of just the, part of the, one domain. But they did this in myositis patients, it didn't work. Why would it work in ILD now? It doesn't really add up. And the preclinical data is bad, and the clinical data was bad. So it feels like there's no chance this could work based on this pretty implausible mechanism. I mean, ILD and sarcoid, there's no one cause of sarcoid. There's a lot of little causes, it seems. It's obviously a very quixotic disease. It kind of comes and goes. Many patients don't require treatment at all. So boosting this signal, if the signal indeed is sort of this gateless, anti-inflammatory, anti-immune signal, which at least when you see the antibodies, you see that it causes this problem, but it doesn't mean that because you add more that there's not a ceiling. Again, I don't even know why the ARS antibody syndrome happens. It's very rare. But adding more doesn't seem like it would actually create efficacy, because you're assuming that whatever ARS is doing, it's going to override all the other disease signals. And then two, that there's even the patient has ARS. So it's not like they're missing it. They have plenty of it. So we're going to add even more. There's no homeostasis and it's gateless. There's no limit to how much benefit you can get from it. So those are really unlikely, especially since we've seen in vascular muscular dystrophy, FSHD, that their old drug didn't work. So that's my kind of general thesis about the therapeutic hypothesis. Obviously, the clinical data, preclinical data, we've covered in other places, but that's kind of where the idea kind of comes out. So I hope that cleared some things up, and we'll keep reading and researching, and we'll see what happens. Thanks a lot, guys. End clip. Cut. Cut it, cut it, cut it. Your price is way too high. You need to cut it. Cut it, cut it, cut it. Did that make sense to you guys? Is that a convincing argument? I mean, the Joe antibodies sort of are convincing that. Oh, I guess the addendum here would have been undefeated, uncontested, best group ever for sarcoid. Placebo. No, I mean, so think about it. If I have an antibody to Rs, I get sarcoid. Okay, let's keep it simple. I have an antibody to Rs, I get sarcoid. But I have sarcoid and I don't have antibodies to Rs. So do I give more Rs? You have to have this theory that Rs is stopping the sarcoid in the first place, which may not be true.